Hey, welcome and thank you for joining. My name is Angelica Cardenas, and I am a health educator for community health at Atlantic Health System. Today's webinar, Learning a New Language, Understanding Communication and Behavior Changes Associated with Dementia Disorders, is presented by Amy Matthews, Dementia Consultant. Before we begin, I have a few announcements. This webinar is being recorded. All participants are muted. If you have questions, please use the Q&A for questions or chat in the comment. We'll monitor the Q&A as Amy goes along in her presentation, and we will also do our best to answer questions at the end of the presentation. At Atlantic Health System, we encourage everyone to be an active partner in their healthcare. We recommend using an online tool called MyChart to help you manage your care. MyChart is an interactive tool that gives you 24/7 access to your electronic medical record. Anyone who is a patient with the Atlantic Health System can open a MyChart account. This includes anyone who has visited Atlantic Health System providers for routine visits or vaccine visits only, or even Atlantic Health System emergency room only. MyChart allows you to manage many aspects of your healthcare. Here are some of the most popular features you will have access to in MyChart. You can request your medical records, send non-urgent messages to your providers, request refills, and much more. If you want to set up a MyChart account or need help logging into a current account or have questions about how to use MyChart, there is help available 12 hours a day, 7 days a week. To you, Amy. Thank you.
All right. Thank you, everybody. Thanks for being here. I saw that hosts and co-hosts can't answer the questions. I'm like, I knew those. So let's get started. What we're going to talk about today is learning a new language. So understanding how communication and behavior change as these diseases progress. And I always like to kind of make sure we're all on the same page. So I like to start with what exactly is dementia? Oh, hang on, just trying to turn this page. It's not turning, Angela. There we go. Nope. There it is. Yay. So, dementia itself, let me start at the very beginning. Dementia itself is actually not the disease. It's merely the category of symptoms. And this is important because a lot of times people hear dementia, Alzheimer's, we even still hear senility kind of used simultaneously or all as the same thing. But dementia itself is just the category of symptoms. So there are typically two types of causes. And the first are neurodegenerative diseases. So neuro is neuron or neurotransmitter messenger. Degenerative means destroy. So that's what these diseases do. They're progressive, so they get worse over time. They are degenerative, so they're literally destroying the brain. And in the case of most of them, they are fatal. The most common disease that causes the symptoms of dementia is Alzheimer's disease, most notably marked by the first thing we tend to see is no short-term memory. So a lot of repetitive questions. You're going to see how this plays into communication. As disease progresses, the person loses the ability slowly to do simple tasks without help. The second most common is called vascular dementia, and that's typically caused by mini strokes or what they call TIAs, trans-ischemic attacks. Vascular looks and progresses a little different than Alzheimer's. So Alzheimer's is kind of a precipitous decline. There really aren't a lot of plateaus where we see no change, but it tends to be slow. The older a person is at onset, the slower it tends to progress. The younger the person, the more rapid the decline tends to be. Whereas vascular has what they call a stair-step progression. So somebody seems fine, but they're having these mini strokes. And enough of these mini strokes will eventually do enough damage that the person seems to suddenly present with a loss. It might be memory issues, might be physical issues, or a combination of the two. It really depends on where those strokes are hitting the brain. But one of the bigger communication differences is with Alzheimer's disease, we said short-term memory or the ability to learn and retain new information is one of the first things to be affected. With vascular dementia, it doesn't, as we say, necessarily affect memory first. And a person with vascular can still learn and retain new information, but it may come and go. And we'll talk about that more as we go. Dementia with Lewy bodies is either tied for second most common or third most common. And basically, it looks like a combination of Alzheimer's, where you have this progressive loss in ability, and also Parkinson's. So, right at the beginning of the disease process, you can see Parkinson-like effects. You can see someone have very rigid arms and legs, kind of have a shuffle gait. Um, People with Lewy body dementia, interestingly enough, about 50% of people with that disease also have a sleep disorder. So we know with vascular and Alzheimer's, people can get their days and nights mixed up, but sometimes by keeping a person busy during the day and making them more tired at night, we can kind of reverse that pattern. But 50% of folks with Lewy body dementia, actually, when they go into dreaming sleep or REM sleep, can become physically active so that the brain and the body never get a good rest. So you tend to see a lot more daytime drowsiness that you can't necessarily reverse the person out of. And then frontotemporal dementias, which we've been hearing a lot about recently in the news. Basically, frontotemporal dementias look and progress differently than the other ones we've talked about. They actually tend to affect younger people. They can affect older people, but more commonly it's between 40 and 60. Frontotemporal dementias also tend to have some very aggressive behaviors associated with them and can have very vivid hallucinations and delusions, whereas that's not necessarily typical with the other diseases. While it can happen, it's not necessarily typical. Just to give an example of how we've heard about dementia with Lewy bodies, the actor Bruce Willis and the actress Wendy Williams have both been diagnosed with with frontotemporal dementias. And then finally, mixed dementia, which tends to be a combination of Alzheimer's and vascular dementia. So someone can look maybe more like Alzheimer's or more like vascular, or just a combination of both of those, which makes it a little harder to diagnose. Often they may suspect that when a person has progressive loss in memory and ability, as well as cardiovascular issues. So those are the diseases that cause the symptoms of dementia. And now let's look at, oh, there we go. Other conditions that can cause the symptoms of dementia. And this is important because these things can certainly affect communication and behavior. But other conditions usually are physical in nature. And kind of our red flag is when there's a sudden change in mood, memory, personality, or behavior, that's not necessarily typical of how the diseases progress, with the exception of frontotemporal dementia. So sudden change, we want to make sure we're ruling out any physical cause for that. Most common cause of those other symptoms of dementia really are medications. The older people are, the longer medications stay in their system, and also the more differently they tend to react. So medications are important to periodically review. Whether you're taking the brown bag of all the meds into the pharmacist or to your doctor, it's important to keep checking every 6 months or so to make sure we're on the correct doses and they're still doing what they need to do. And if you look at the side effects of a lot of medications, memory loss is one of them. So that's why it's important to make sure we rule that out. Clinical depression can cause the symptoms of dementia. And by clinical, we mean typically more of a chemical imbalance, which can be determined through depression scales and also blood work. They look at that. Depression tends to be more undermanaged in the elderly because of the medication piece. It's harder to find the right medication or combination of medications for an older person. But it's worth that trial and error to allow someone to kind of be functional. Then certainly vitamin deficiency, the Bs, niacin, thiamine, B12 can cause issues with memory. Certain tumors or infections, blood clots, anything that puts pressure on the brain changes how it works. So if we are able to relieve the pressure, and that's the sole cause of those symptoms, then that person may regain full function, full cognitive function. Metabolic imbalances that aren't being managed, kidney, thyroid, and liver, can all cause issues with memory. Also, malnutrition, and the biggest one, dehydration. Dehydration tends to be the number one reason that seniors go to the ER. And dehydration can present itself as all of a sudden the person gets more confused and often more agitated. So dehydration can happen even when we're trying to be conscious about drinking enough fluids. It's important to watch for that. And then finally, urinary tract infections. typically manifest in all of a sudden somebody tends to get more confused and disoriented. So the reality is, diagnosis is the important piece here because we don't know necessarily if it's a disease or something physical that we be able to manage. And the reality is, often people have multiple causes of the symptoms. So someone may have a disease like Alzheimer's or vascular dementia, but they also may have medication side effects, be dehydrated, and have a urinary tract infection. And those three things will just magnify the effects of the disease. So any concerns, especially when we see sudden change, and this absolutely affects communications and behavior, we want to make sure we rule out the physical things. Any questions there so far? And you can, if you have a question, please feel free to put it in the chat. And I know Angelica is going to help me monitor that. So we'll move along. So let's talk about communication and behavior. Now, I call this the first part of this title is learning a new language, because I really want us to start to learn the language of a dementia. Again, first of all, dementia is not the disease, right? It's the category of symptoms. So when we hear that term, we want to say, well, what's causing those symptoms? And just so you know, they can be 90 to 95% accurate at diagnosing the cause of the symptoms of dementias. Now, we're getting closer. They're talking about a blood test that may be able to diagnose it very, very early, even before we see symptoms. Currently, it's basically a rule out diagnosis where, through a series of evaluations, medical, physical, psychological, cognitive, blood work, scans, medical history, social history, they can kind of rule out other causes and more specifically hone in on what is causing it, but 90 to 95% accurate. So let's talk about communication and behavior. And you see my little picture here. This child is yelling because it's all in caps. Behavior as communication. What does that mean? Well, we're going to talk about that because we're going to redefine what behavior really means. So first I ask, how do we communicate? I'm going to ask you folks just to think for a minute. How much of all you communicate on a daily basis out of 100% is talking? And I'm talking about not with a person with a dementia, but with friends, family, coworkers, people on the street. I'm Midwestern. I say hi to everybody. How much of all you communicate on a daily basis is talking out of 100%? And I'll ask you to put that into chat so that we can just kind of get a sense of the numbers. And Angelica, were you gonna,
Yeah, there was a question on what you were
please?
touching on earlier on dehydration. The question
Mhm.
is, can dehydration exacerbate a dementia disorder disease irreparably, or once rehydrated, nourished, those exacerbated symptoms, quote unquote, improve?
That's an excellent question. And actually, typically, once the dehydration is addressed, that person tends to come back to their normal level of confusion, if it will. So it's not typically irreparable. The problem would be if the dehydration goes unchecked and gets worse, then you have all kinds of other physical things that can start to happen. But once the dehydration is managed, and we always want to check that first, that and UTIs, typically that person then will kind of come back to their normal level of confusion due to the disease process. So did we have many folks put in the
No, I'm
percentage?
seeing
That's all right.
someone has their chat disabled, so I'm just going to check on that while you all continue.
And no worries. I want you to think about that though. This is an important question because honestly, I think most of us tend to think the majority of what we communicate is talking. And that becomes important because when someone is losing the ability to have a conversation or has difficulty speaking, then we start to think we can't communicate with them, right? So it's important to be aware of your perception of communication because that directly affects how we act and interact with the person with the dementia. So the reality with this is, I'm trying to get that. There we go. This might surprise some of you. Only about 10% of all we communicate on a daily basis is talking. The other 90 is nonverbal. So that becomes important. We can read people very well. We just don't tend to trust ourselves. As I say, we kind of rely on the words. But really, behavior becomes our most accurate and is our most accurate form of communication. It already is. So we want to start to become sensitive to that because when a person has a dementia, Um, Behaviors aren't always negative. They are communication. They are how someone is communicating. So that's a good statistic to throw out at your next gathering or party because we tend not to remember that. So process of communication, what our brain does, just to pull a thought. We have to access multiple bits of information that are literally stored all over the place, pull them together, process them into something that makes sense, and then communicate that. Um, Also, simultaneously, we are constantly assessing the things going on around us and adapting to them, um, aka attention span. So, just to pull a thought, your brain does all that, and certainly without our being aware of it. However, when somebody starts to have issues with their communication and thought processes, they actually become more aware of it, which is where we can start to see behaviors like frustration and agitation. The see, some folks put, I did have someone put 10%, well done, and someone put 50%. And I've had people say 210%. So it's just important to be aware of our perception of communication. Now let's look at the process of communication for somebody with the dementia. Um, it can feel like this image. And I think all of us have probably felt this way at one time or another in our lives. But this is important. As diseases progress, the brain has a harder and harder time accessing and retrieving all those bits of information that are needed to complete a thought. So as diseases progress, thinking can become more fragmented. Also, as disease progresses, it gets increasingly difficult for the brain to filter out activity and background noise. So attention span gets shorter and shorter. And if you've ever had those days where there's just too much going on that you can't focus, that's what it can feel like for the person with a dementia all the time. So whether we're visual or we need the words, you can see and read what communication can feel like for the person with dementia. And again, imagine feeling like this, just trying to focus on something and just pull that thought together. You know what you want to say, and it's not coming out. How that can affect how people behave and act and interact. So the types of communication, there are two types. There's verbal communication, which is basically words, singing, shouts, noises. Again, what we tend to think is how we communicate most effectively through the words. And then there's nonverbal communication, which we typically refer to as body language. But I want us to start to think about that differently. So here we go again. We're changing, we're learning this new language of dementia. Body language is more than just body language. There are separate pieces of it. And when we're caregivers or interacting with a person with Alzheimer's or related dementia disorder, we literally want to become aware of all that body language includes, because that's what the person with the disease is reading. So nonverbal includes things like posture, right? If someone normally has a straight upright posture and now they're kind of either stooped to the side or lower down, that can tell us a lot. It can tell us maybe the person's not feeling well, maybe the person's tired. Um, and we interpret body language better than we realize. We just have to give ourselves credit. Eye contact, unless there's a visual impairment, eyes are the one way you know you're connected with that person. So it's important to maintain that eye contact. You can be in a room, you can even be in front of the individual, but if you haven't gotten that person's attention and have that eye contact, the individual may not even know you're talking to them. um, Facial expressions. I always giggle, and we all know who we are, right? Some people's face does things without their knowledge. It becomes imperative to become aware of your facial expressions, because you can have the right posture, the eye contact, say all the right things. But if your face is sending a different message, that's what the person is reading. As the words fade for the person with Alzheimer's or related dementia, body language, nonverbal communication becomes our most accurate communication. And these individuals can read us faster than we open our mouths to talk, and often very accurately. Also, meaning that a lot of times the behaviors we see, sometimes either the environment, the physical space, or we actually cause because we're not aware, and calming things down. Touch. Touch is a powerful form of communication. It's one that we have to be careful of, because touch can convey many things. It can convey safety, love, support, attention. But if someone were ever experienced a trauma, we don't want to touch someone without permission, because touch can also um, elicit, if someone had a trauma, can elicit memories of that event and make the person kind of step back or startle the person. So we always kind of want to ask permission. I always say, put your hand out for a handshake, or may I give you a hug? We just don't want to presume and just go up and hug or touch a person without their permission, or connecting with them through that eye contact. Position. And now position means two things. Position is whether a person is seated or standing. If someone's seated and you're standing, ideally you want to get at eye level with that person, because standing over somebody can be misinterpreted as we're being domineering and kind of cause that person to shut down. Um, you also want to think about personal space when we think of position. Our culture in particular is very funny about personal space, right? There's a literal point when you're walking down the sidewalk and someone's walking towards you where the heads both go down because we don't want to make eye contact. So we want to be aware of that person's comfort level. I've found that a lot of folks in their, let's say, 80s, 90s, 100s, like to be very close and talk to you. Not everybody, we're all unique and individual. But if that is uncomfortable for you, we want to be aware of what we're doing. So if someone's talking very close, a lot of times unconsciously, we kind of step back or move back. When you're communicating with someone who's reading your nonverbals most accurately, sometimes just that moving back can cause that fight or flight reaction. So we want to become aware of what the person's showing us and also what we're showing the person, because that's the true communication. And gestures and movements. There are open gestures, your hands at your sides. There are closed gestures. I don't know if you can see, I'll move this a little bit, but like having your hands crossed, that's comfortable. And a lot of us do it. But believe it or not, it actually creates a barrier and sends a different message. So ideally, we want nice open gestures and movements. As we age, everything slows down. So, walking, talking, it takes us longer to kind of process what's going on around us and to react to that. Add to that Alzheimer's or related dementia, and you can magnify it. So even walking up to somebody at your normal pace may create a sense of crisis. So when we're interacting with that person in terms of communication, to avoid any negative reactions, we want to slow everything down and kind of announce our presence. Then finally, tone of voice. We don't always associate that with nonverbal, but it absolutely is. You can say all the right words, but if you don't have the tone to match that, the tone is what the person is reading. If I said, "Oh, I'm so happy to be talking to you people today," I said the right words, but my tone sent a different message. So we want to be aware of all these things. Now, are you going to remember all these things when you're communicating with somebody with Alzheimer's or related dementia? No. What I want you to remember is that we become a mirror. So whatever you're showing, whether you're aware of it or not, that's going to be reflected back in how the person reacts. So if someone is reacting negatively or right off, first thing we want to do is take a step back and kind of look at what's going on around us, right? Because remember, attention span's getting shorter. It's harder for that person to kind of filter out background noises and activities. And we now are starting to have someone relying more and more on body language, those nonverbals, as the most accurate form of communication, less about what we say, more about how we say it. Any questions so far with that? Okay, if you have them, just pop them in the chat and we will get to them. So next, new vocabulary word here in our learning of a new language and how these diseases really do affect communication and behavior. But you're starting to see emerging things, right? It's not communication and behavior, it's communication as behavior. Um, but basically, what the neurodegenerative diseases cause: Alzheimer's, vascular dementia, dementia with Lewy bodies, frontotemporal dementia, mixed dementia, and all the ones that kind of fall under those. It causes progressive brain damage. And I have found over, and I've been in this field for almost 35 years, that just that subtle switch in terminology helps us see this differently. In terms of Alzheimer's or dementia, we tend to think, forgetful, but they know what's going on. When we hear the term progressive brain damage, we start to think differently. When we think of brain damage, whether you've known somebody with brain damage or not, we start to think, okay, well, they don't process things quite the same, and they may have different reactions to things. This is brain damage. If you look at the pictures, this is a depiction of the progression of Alzheimer's disease in particular. Um, I apologize. Karen says I am on mute. Um, I'm not sure. I
I can
think I'm
hear
not
you.
on.
I'm
Oh,
addressing Karen's question in the chat.
oh, thank you, thank you.
Yep.
So if you look at this picture on the left, you see the progression of Alzheimer's disease. The top is early stages. Look how full that section of the brain is. The middle picture is moderate stages. Do you see how the brain's starting to shrink and becoming devoid of ridges? And then end stage, you can see the difference. And the picture on the right clearly depicts the difference, right? And how this is brain damage. The left is a healthy brain. The right is end stage Alzheimer's disease. So it's way more than forgetfulness because your brain controls every function of your body. It controls not just the cognitive things, how we think, how we process, how we communicate, how we interpret, but then eventually in later stages, it starts to control the physical things, our ability to walk, our ability to eat, our ability to perform all those what they call activities of daily living without help. So I have found that just using that term progressive brain damage as caregivers helps us, no pun intended, remember that this is more than just forgetfulness. The person is losing the ability to do things. Okay, move forward here. There we go. Oh, it went backward. Sorry about that. There we go. See, I'm testing you guys. That was our recap. Now we're going forward. This is kind of sticking a little bit. Angelica, I wonder if you could um, help me advance to the next. There we go. It's moving now. And then we'll go to the next one. There we go. Now we're together. So I'm going to use Alzheimer's, if I may, as the example, because that's still the most common disease that causes the symptoms of dementia in terms of how it affects communication and behavior. If anybody has specific questions about one of the other diseases and how it may be a little different, please feel free to ask, and I will answer that as best I can. So with Alzheimer's in particular, one of the first parts of the brain that's typically affected, you hear me say typically, it isn't always, but the majority of time it is. So typically affected is the hippocampus. And you can see in this depiction, the little green part of the brain there is the hippocampus. Basically, your hippocampus is your memory processing center. So it's kind of the gateway through which all new information goes through and gets coded and stored in multiple parts of your brain. And I always say that your hippocampus is kind of like your mom because it knows where it put things away when you want to retrieve that information. Then the hippocampus goes and finds all those bits and pulls them together and processes them into something that makes sense. So with Alzheimer's in particular, very early in the disease, one of the first parts of the brain that's damaged is that, and we tend to see someone forgetting things. So basically the gate shuts, and no longer can the person with Alzheimer's take any new information, no matter how many times you repeat it, no matter how important it is, no longer can they commit that to long-term memory to be recalled later. So forgetful isn't even the most accurate term here, because to forget something that was in there to begin with this part of the brain being shut off, basically the person cannot learn and retain new information. Now that becomes important with communication and behavior because where we sometimes think someone's doing something on purpose, oftentimes it's because the hippocampus isn't able to pull all the information it needs for that person to complete that, if that makes sense. And I see we've got some more questions in here. So let me just, oh, we got a hooray. All
Yep.
right, good. Welcome back. Excellent. Okay, just giving this a sec to advance. There we go. So let's look at how the process of communication becomes disrupted. And again, I'm using Alzheimer's as the example here, but we can certainly relate it to the other diseases as well. With Alzheimer's, typically, verbal speech gets affected relatively early, and you get those repetitive questions. And you can see more frustration because someone knows what they want to say or doesn't remember that you just answered that question and thinks you haven't answered it. So, how this communication processed in the brain? If you look at the images on the left here, you'll notice that what we call receptive language, which is basically how you understand written and spoken words, receptive language is processed in multiple parts of the brain. So the top left is reading, um, the top right is thinking, the bottom left is seeing, and the bottom right is hearing. So receptive language takes place in multiple parts of the brain. And then if you look at the picture on the right, the blue shows the brain damage, right, as disease progresses. So with Alzheimer's, the first area typically affected is that hippocampus. So the ability to learn and retain information is affected early. But other than that, the person typically can live independently. People can still work. People can still drive. Oftentimes, as family and friends, we may not necessarily be aware that the person has anything going on. But if you look in moderate stages, you see how that damage is now starting to pervade more areas of the brain, starting to hit more areas of receptive language. So in moderate stages, we start to see a person having a hard time carrying on a conversation or initiating a conversation. You may see a person kind of having what they call word salad, where there's made up or mixed up words because they can't remember the accurate word. You tend to see more what we call forgetfulness, but more repetitive questions and not remembering things. And interestingly enough, if somebody's primary language is not your own, as the person begins to go into moderate stages of the disease, they tend to revert back to their native language because that's more deeply ingrained in long term memory and still accessible, where newer learning starts to be destroyed by the disease, if that makes sense. And also, really moderate stages where we make that 10% leap from 90% of all accurate communication being nonverbal to really 100% of all communication being nonverbal. Moderate stage, funny enough, is also where we tend to see more behaviors. But again, part of our new language is we want to really look at behaviors as communication. Thank God for behaviors, because without them, um, the person can't verbally tell us what's going on, but what I promise you is that person's going to show you everything you need to know. We just have to learn to see it as opposed to hanging on to the words. In the moderate stages is also where we start to hear that term less communicative or non-communicative. I want you to take that out of your vocabulary completely. People are never non-communicative. A person may be nonverbal. They may lose the words or not have the accurate words, but communication is still happening both ways, 100%. Then, if you look at the bottom picture, that's really late stage of Alzheimer's in particular. And you see that that damage really has pervaded all the areas of that receptive language, but communication's still happening. The person may have one or two words or no words, but behaviors really take on even more meaning at this time. And the person still absolutely benefits from receiving communication and is still showing us the things we need to see. So I always think that's important to remember as the caregiver. The communication never stops. Also important to note, especially when we're interacting with folks, that in the early and moderate stage, there are many moments of awareness. Awareness doesn't mean I remember everything. Awareness means I'm right here, right now, in the moment. Even in the end stages, although few and far between, there are still moments where that person is aware. So it's important when we're interacting with the individual to always remember respect and dignity and treating the person as an adult, because you never know when that moment of awareness is going to come or go. So we always want to be in it, if that makes sense. Now we're going to advance to the next slide here. There we go. So, communication pitfalls. Please don't read ahead, because you're going to read these and say, I have done all these multiple times. I can't believe it. We've all done them. We'll all keep doing them. Here's our advantage. When you look at these diseases as they progress, what I promise you is that the person won't remember. But if you hold on to it, if you hold on to feeling guilty because you yelled or argued with somebody, um, you wear it. And that's what the person reads and reacts to. So we need to let ourselves off the hook. As bad as an interaction can go, I promise you, the person with the disease will forget it. You need to let yourself off the hook. But some communication challenges or pitfalls: arguing. Arguing is for someone who's in our reality. Basically, what happens with these diseases is the person's getting ripped back and forth between past and present without warning. So they're not in our reality. We need to enter wherever that person is. So if the person says, "You never told me that," ideally we want to think, "Oh, I told you a million times." Don't say that. Say, "I'm so sorry. I thought I told you. Forgive me." And we can often move past it. Um, but arguing is for our reality and the person isn't in it. They're getting ripped back and forth. An example of that is you can talk to someone, they're right with you, come back a little later and they're saying, "Honey, you need to help me get home because I have to pick up my children." And you are the adult child. That's that ripping back and forth. Trying to explain to somebody with progressive brain damage who knew it and the disease is destroying it often can be misinterpreted as we are talking to them like a child or being disrespectful, and you're going to get the same reaction. One thing I always like to say is that, believe it or not, we all know what it feels like for moments to have these diseases. So use your own experience. You know how you feel if someone's trying to explain something to you that in your mind you already know. So use your experience to kind of help you through those moments with the person. Telling a person, and PWD is person with dementia, telling a person with dementia what they can do and can't do. Who do we talk to like that? Children, right? So we have to always kind of remember that this is an adult who knew it and the disease is destroying it. So as opposed to telling someone what they can and can't do, in order to minimize negative reactions and to kind of give that person more control, we want to adapt the environment so we don't have to say it. Adapting the environment isn't just physical space, it's social and emotional. It's how we engage the person and how we support the person. So if you have someone trying to walk out the door unsupervised and that's not the best idea, saying, "No, you can't do that," to an adult whose long-term memory is telling them they can, it's probably not going to go the way we hope. But maybe saying, "Oh, I'm so sorry, before you go, would you mind helping me with this?" sometimes is enough to kind of redirect that behavior. Everything doesn't always work. That's why we have to have a bag of tricks, if you will. And I'll talk about that a little more in a moment. Oops, that one jumped on without me. Hang on. Um, Talking to the person like their child, talking about the person as though he or she isn't there. Ideally, people know when they're being talked about, and it doesn't make any of us feel good. That's no different when someone has Alzheimer's or related dementia. And talking to the person as a child, we just said, we don't like that. So the person who knows it, their long-term memory is telling them they're right. Um, it's not going to go the way we hope. Asking too many questions, because the brain damage is causing the person to have a hard time processing information. Remember that image, right, where the head explodes. Asking too many questions can cause someone either to get really frustrated or shut down. Has to be one thing at a time and allow time for response. Watch the person. You can tell by looking at them. Are they thinking about it? Are they on to the next thing? Or are they not understanding what you're asking? And then we redirect. And raising your voice. Now, this is a challenge because if someone is hard of hearing, our natural tendency is to raise our voice. But oftentimes, raising your voice often is misperceived as we're yelling at the person. So if someone is hard of hearing, watch them. A person typically will lean in with their better ear. That's the one you want to talk to. Establish eye contact. Here's your nonverbals coming back. touch if appropriate to get the person's attention. And for women in general, our voices tend to be a little higher. And many people's hearing deficit, not everybody's, many people's hearing deficits have to do with they can't filter out background noise. And the higher voice tends to blend in with background noise. So if you can drop your voice and speak in a clear, direct tone, that may change how the person can pick it up and not think that we're yelling at them. And we're doing okay. Any questions? I see one question here. It says, what the, PWD means person with dementia. It's honestly just takes up less space. But thank you for asking that. Person with dementia. You're most welcome. Now I'm going to try to advance. Here we go. So what's the biggest communication challenge with people with Alzheimer's and related dementias? I just think that picture's fun, so forgive me for putting that there. The biggest challenge, especially with people with Alzheimer's in particular, because it tends to spare physical health to the later stages, is they don't look sick, right? That's why I keep saying that term progressive brain damage, because when we hear it, we think differently. But when we hear Alzheimer's, we hear dementia, we think forgetful, but they know what they're doing. It's a challenge, right? Because there's no visual reminder that this person has brain damage. And that can be the biggest challenge because we're talking to the person that we've always known, like we've always talked to them. And it's hard to kind of step away from who the person was and to how this brain damage is affecting them. So what do you think of when you hear the term behavior? And again, honestly, we typically think of negative or challenging, right? I hear they can get violent. I hear they can go off for no reason. Well, first, there's no they. These diseases, all of them, affect people as individual and unique as that person is. Are there some commonalities in how things progress? There are some, but it tends to actually kind of show the true personality. So if somebody was always kind of cranky and agitated, it's going to magnify that. That person's going to be more cranky and agitated, but now they have an excuse because they have progressive brain damage. If somebody seemed like they were always kind of cranky and now they're sweet as pie, and you're thinking, where was this person? As a person progresses through the disease, newer learning fades away. So past becomes present. So as that person goes back into long-term memory, any walls that life experience built up get knocked down. So the true personality will begin to emerge. And that's important to note. So it doesn't also typically change personality. It tends to magnify personality. We just may not have known the true personality that was in there. So it's important to note that behavior, by its very definition, isn't negative or positive. It's literally how a person responds to internal and external stimuli, right? This also helps us understand that in terms of interpreting behavior, the person's going to show us everything we need to know. We want to become very sensitive to the environment, the things around us, because 9 times out of 10, the negative reactions, as well as the positive ones, are a result of something in the environment. And again, that's the physical space, it's the social, how we engage that person, and the emotional, how we support that person. So we want to think about those things. Behavior is communication. Behavior is probably the most positive thing we have right now, because without it, we wouldn't know what was going on. And we tend to focus on the negative behaviors because obviously those are more glaring, but think of positive ones too. It's a smile. It's that moment of awareness. It's being able to have a great interaction with the person that maybe you hadn't had in a long time or never had before. So behavior is communication. We need that. Behavior doesn't come out of nowhere. Now, I'm going to preface this a little bit. Remember, we talked about the different types of neurodegenerative diseases that cause the symptoms of dementia. Alzheimer's, vascular, Lewy body. Lewy body can have vivid hallucinations and delusions associated with it, and that's basically how the disease is affecting the brain. With Alzheimer's and vascular, you can have them, but they're not necessarily typical. And oftentimes it can be a misinterpretation of the environment as opposed to a hallucination or delusion. What's an example of that? Maybe you walk into somebody's home and they come up to you frantically. Thank God you're here. There were people screaming, and I don't know what's going on. I heard police sirens, and you're looking around, and none of that's happening. But you notice that the television's on and it's a police show. So if the person's not connected to the TV, it just becomes part of the background and they just incorporate it into their reality. If we turn off the television, and validate what that person says. Oh my gosh, that must have been so scary, but it seems like it's calming down now. A lot of times we can ease the person out of that. Whereas if it's a true hallucination or delusion, you basically have to ride it out until it subsides. You can't talk or calm a person out of it. So, in terms of behaviors, with the exception of frontotemporal dementias, where it typically does come out of nowhere, oftentimes, there's a reason for the behavior. There are often subtle cues. People don't usually start here, they kind of escalate, right? So always check the obvious first. Is the person hungry, thirsty, or do they need to go to the bathroom? If somebody's hungry, you've heard that term hangry, it can cause a person to be agitated. Or thirsty, are they dehydrated, which can cause more confusion and agitation. Unfamiliar or changing environment. It's not saying we can't take the person out of their most familiar environment because every environment's going to become unfamiliar. But making something familiar and comfortable is also how we're engaging that person and supporting that person. But if it is daylight savings time, um, when it's getting dark earlier, that can be very disorienting, and not just to the person with the disease. It can be to us as well. If you think about it, right? It's 4 p.m. and dark out, you feel like it's 10 o'clock at night. It takes us time to adjust. So for a person with Alzheimer's or related dementia, they can no longer adjust and adapt to any environment. So we have to adapt the environment to that person. So in terms of daylight savings time, as it's getting darker outside, we want to turn on more lights inside and keep more even lighting to help kind of minimize or reduce that effect. And then finally, our own approach. Remember, you're a mirror. So whatever you're showing is going to get reflected back at you, whether you're aware or not, either positive or negative or indifferent. So this is a great tool to help us interpret behaviors. It's called the 6 W's. And the most important thing you can do for any behavior, which is communication, is look at it in the moment it's happening. We often say, he always does this, she always does that. There could be different reasons or different triggers. So we want to look at it in the moment it's happening. So the first question you're going to ask yourself with a behavior is, what is the behavior? Think very hard on how you label it, right? Because the words can cause us to go down a negative path or a positive path. And in all honesty, when we see a behavior, we don't know yet if it's negative or positive. The second thing you want to ask is, who's involved in it? Is it just the person with the disease? Is it you? If the person's in a care setting, is it other staff, other residents? So who's involved in the behavior? Then you want to ask, when does it happen? And you want to be specific, because there are some behaviors you can literally set your watch by. So when does it happen? Is it always at 5 o'clock? Is it always when it gets dark out? Is it at 8 in the morning? Then you want to ask, where does it happen? And be specific, just like the time. It happens in the kitchen, but where in the kitchen? Is it in front of the window? Is it by the sink? Where is it? Then you want to ask, and this is where you can be creative, why is it happening? And the 6 W's kind of help us put together a puzzle. Next thing you want to ask is, what do I do? There's only one of three things you can do with any behavior. You can redirect it because maybe it's negative. And redirect doesn't mean just try to, switch someone without acknowledging it. We have found that redirecting often takes validating how the person's feeling, which you can read even if you don't understand the words. Watch the person. You can hear in the tone, you can see the facial expression, the posture, the movements. If someone's relaxed, if they're angry, if they're frustrated, if they're frightened. And you want to acknowledge that first and then move on to the next thing. We can reinforce it because guess what? Maybe there's something positive there that we want to keep up. So if we have the person who's constantly rubbing things, maybe we can reinforce that because it's going to help with dexterity. It's going to give purpose by handing the person a rag and saying, would you be kind enough to help me dust off this counter or wipe off this counter? So we give it a purpose. Or sit down for this, we can do nothing because sometimes the only person it's bothering is us. It's not negative, it's not creating a safety risk. It just is driving us crazy. And in that case, take a deep breath. If it's safe to do so, walk away for a moment, regroup, and come back. Because if it's not harming anyone and it's giving that person a sense of purpose, then it's okay. So I'll give you a quick example. I had a resident in an assisted living. This was dementia specific, who every day this woman would come into the kitchen and it was kind of designed like a house. And she'd start walking back and forth in front of the bay window. And as she's doing this, this would be about um, probably about 4:30, close to 5. She'd start getting more and more intense and saying, where, and she's looking out the window. And as this is happening at that time of day in a care setting, you have residents coming back to the care setting, doing personal care, getting ready for the meal, and whatnot. When we finally get her seated for dinner about 5:15-ish, it would calm down and be done. So there's the snapshot. Okay, so we're going to say, what's the behavior? You want to be careful. I said walking back and forth. A lot of times people say, well, she's pacing, looking for. Pacing has a negative connotation. So be careful of your words. Who's involved in this particular example? Everybody, other residents, staff, and certainly her. When does it happen? You could set your clock by this lady, 4:30 to 5:15. Where does it happen? It was in the kitchen in front of the window. Why was it happening? Could be lots of reasons. Think about that. So why would you be in the kitchen at that time? Maybe the kids are coming home from school and you have to get a snack ready. Maybe you're waiting for your husband to come home. Maybe it's time to start preparing dinner because everyone's coming and you don't see them coming. Why did it happen? Um, think of the way you answered the question above that, and we can start to put that puzzle together. And then what do I do? Clearly, she was distressed. So for her, we needed to redirect. Now, that was sundowning. Sundowning always has a start time and end time, and typically is environment specific. So with that behavior, we get her at 4 o'clock, steer her completely clear of the dining or the kitchen, because that's where it was triggered, and engage her in something she enjoyed. It may have been something different every day, but oftentimes that would ride her through that time without that anxiety. So that's kind of where that comes in. Behavioral triggers. The environment can certainly spark behaviors, good, bad, and ugly, right? So the calmer the environment, because remember, the brain damage is taking away the person's ability to filter out activity and noise. So if there's too much going on, either the person gets frustrated or they shut down. The calmer the environment, the more control we give that person back. Perception, the brain damage affects how people perceive and interpret the environment. So if it's getting dark early, it's going to be perceived as it's night, I got to go to bed, or I'm getting up at 5 a.m., because I have to get to work. So ideally, we keep adapting the environment to what's going to make the most sense to where that person is at that moment in their progression. Physical changes, when we don't physically feel well, right? We don't have the stamina. We can be more agitated. We can be more uncomfortable. So think of things that help you through that. Think of things that always help the person, because remember, the diseases affect people as unique and individual as they are. And illness. And illness often can present in sudden behavior change. Maybe the person who's usually active is now lethargic or more agitated because they're uncomfortable or in pain. Important things to remember: validation. Validation means to focus on the emotion, not the words. The person's going to show us everything we need to know, but it is a basic human need to feel validated. So if someone says, I need to get home, and they are home, we don't want to just say, well, you're home. Because if I thought I was home, I wouldn't say I need to get home. So what's the emotion? Oh my gosh. Um, I know what it's like when you can't get home right away, and use things around you, but it's dark right now. Why don't we stay together and we'll figure this out later? And sometimes that can help you through. You have to have a bag of tricks. Not one thing always works. Redirection means to distract the person from the negative thing and redirect to something more positive. But you first have to validate how they're feeling before that's going to be successful. And then therapeutic explanations, because a lot of times we struggle. What do I say? Do you lie to the person? Do you always tell the truth? Well, therapeutic explanation is the truth, but not the whole truth. So it's the truth for where the person is at that moment in their long-term memory. So if I say to you, have you seen my husband? And you know he passed away. I didn't say, did he die? Right? I said, have you seen him? A therapeutic explanation is, I haven't, but I'll keep my eyes open. And that can also create an opportunity to reminisce and talk about, you met in college, didn't you? And get the person on to something else, if that makes sense. Okay, and I'm going to advance. I'm going to try to advance. There it is. Now that's my part. As you can see, the end is near, and there's the end.
Thank you so much, Amy, and thank you all for joining us. We kindly ask that you take a few minutes after the webinar to complete the program survey. The link will pop up for you once the webinar ends. I've also added the survey link to the chat for your convenience. If you have additional questions or comments, you are welcome to send an email to communityhealth@atlantichealth.org, or you can call 1-844-472-8499. That concludes our webinar.